This conference will now be recorded.
Hello?
Hello.
Yes, sir.
Hello. Hello,
Yes,
Pawan
sir.
Kalyan.
Yes, sir.
Hello. Hello, Pawan Kalyan.
Hello, sir.
Am I audible?
Yes, sir.
Okay. So today, almost we are coming to a end of our GAT. So today we will be discussing about the tumors of the liver. In tumors of the liver also, we will be only discussing about the benign tumors of the liver. And coming to the malignant tumors of the liver, we will be discussing in our next class. So coming to the benign tumors of the liver. So so these benign tumors, usually these benign tumors don't cause any discomfort to the patient. These are incidentally found during routine ultrasound for some other cause. So if the patient has some pain in the loin, and if you screen for the ultrasound of the abdomen to check for any renal calculi, in such cases there will be, you may accidentally find these tumors. So coming to benign tumors, first one is the hepatic adenomas. These adenomas are rare. These are the rare vascular tumors. Per se, they may not cause any complaint to the patient or any discomfort to the patient, but sometimes they present as abdominal mass. When they increase in the size, usually the patient presents with mild abdominal discomfort or pain with associated bleeding. So these patients, while on examination, you will see there is abdominal mass present in the right hypochondriac region, which maybe on a routine examination you may not find the bleeding. On a clinical examination, you can't diagnose the intraperitoneal bleeding, and there will be. It is more common in women who are on oral contraceptives, androgens, and anabolic steroids. So if these hepatic adenomas, when they cause the intraperitoneal bleeding and discomfort to the patient, the usual treatment for these adenomas is resection. And these hepatic adenomas have a propensity to increase in size during pregnancy. And when the adenomas are large and which are rapidly growing in size, and they occasionally get ruptured. So when these adenomas rupture, they cause intraperitoneal bleedings. So all this, so care should be taken, and a periodic screening of the adenoma, size of the adenoma, should be dealt in patients who are pregnant. And coming to this, then if there is any chance of rapidly growing of adenomas, in that cases, such resection, surgery in the form of resection is usually done. So coming to hemangiomas, out of the all benign tumors of the liver, hemangiomas are the most common, and these hemangiomas are present in 1 to 20% of the population. And these mostly won't cause any symptoms. There are accidental findings only, and to confirm the hemangioma, CT of the abdomen is required, and the CT shows there will be low density lesion with delayed arterial filling. If these hemangiomas and adenomas, if these hemangiomas increase in size, or when there is every chance of rupture, so in these cases, then surgery is usually done. So next one is focal nodular hyperplasia. It is this type of benign tumors are common in women less than 40 years of age, and these are asymptomatic, And the close differential diagnosis for this focal nodular hyperplasia is adenoma. So only the CT or MRI is usually differentiate the adenoma from focal nodular hyperplasia. And in CT, in case of focal nodular hyperplasia, you see a focal central scar usually present, and rare surgery is rarely indicated in these patients. So in patients who have impending abnormal difficulty in those patients, the surgery is indicated. Next, coming to the cystic liver disease. Cystic liver disease, in what is a cyst? What is the definition of a cyst?
Fluid-filled cavities surrounded
I
by
couldn't
an
hear you. Be louder.
fluid-filled cavity surrounded by an lining epithelium.
Right. Cyst is a fluid-filled cavity which is surrounded by an epithelium. So the in case of liver cyst, cystic lesions may be single or multiple, and they can be associated with renal cysts. These are mostly benign cysts, and when these cysts are increased in size or when there are multiple cysts, they cause mild abdominal discomfort and which requires surgery. So this is about cysts. And coming is liver abscess. What is an abscess?
Infected cyst, sir.
What? Abscess.
Infected cyst.
Infected cyst is abscess. See, the liver abscess usually are divided into three types, which is pyogenic and hydatid and amoebic. So pyogenic, coming to the pyogenic liver abscess, it is usually uncommon when if in case if it is present, it carries a significant mortality and morbidity if untreated. So mostly the cause of mortality and morbidity is underdiagnosed. That is, if you will search for some other cause for the fever, and finally when you identify that there is a liver abscess, in that case it will be more damage will be occurred, and it leads to morbidity of the patient. And the mortality rate is also 20 to 40% in case of liver abscess. So as I already said, the most common cause of death is failure to diagnose. It is most commonly seen in patients of old age, and in old patients are also more prone for higher mortality. And what are the causes of this pyogenesis? These are the most common causes are biliary obstruction due to cholangitis, hematogenous spread from portal vein or hepatic artery, that is mesenteric from portal vein via mesenteric infections, and hepatic artery, the bacteremia. And next one, diet extinction. Next by trauma, whether it is a penetrating or a non-penetrating trauma, or infection of the liver tumor or cyst. So what is the pathophysiology? The pathophysiology, as I already said, it is more common in older individuals and also in immunocompromised states. And when single lesions are usually more commonly seen in the right lobe of the liver, whereas multiple abscesses are usually due to infection secondary to biliary obstruction. So what are the most common organisms that are seen? The most common organisms being E. coli, Streptococci, and particularly in Streptococci also, particularly Streptococci milleri is the most common organisms that are seen in pyogenic liver abscesses. So when there is an infection from the large bowel, then in such conditions, you will see the organism being anaerobes, streptococci, and bacteroids. If in most of the patients, that is more than 1/3 of the patients, you will see multiple organisms are present in this pyogenic. Then what will be the clinical features? Usually, the patients with the pyogenic liver abscess or any patients who are having high grade fever, they will be ill looking. That is, there will be toxic look of the patient, and there is a history of fever and history of weight loss is usually present, and there will be abdominal pain. This is the abdominal pain is the most common symptom with which the patient presents to a casualty or to the OPD. And the abdominal pain is usually present in the right hypochondrium, and on examination you will see the liver is enlarged and it is tender on palpation, and there will be, if there is a biliary obstruction in those patients, you can also observe there is jaundice is usually present. And what are the investigations? So investigations are most commonly complete blood picture, which is usually done to see whether the there will be infection counts will be increased, and LFT is usually done to rule out whether there is any jaundice. And imaging modality of choice is ultrasound of abdomen, which shows there is a cyst lesion and cysts are present, and CT abdomen clearly identifies the size of the cyst and number of the cysts. And then FNAC by ultrasound guided FNAC is usually done to see for abstracting the cystic fluid and for culture to know the appropriate organism and appropriate treatment and that antibiotic sensitivity. And sometimes the SHX shows there will be increase in the right diaphragm, and the right side of the lung is usually collapsed, because this collapse occurs when there occurs the spread of these abscesses, the abscess into the lung, causing right side of the lung, causing it collapse, and sometimes there will be effusion at the base of the right lung. Sometimes the blood, you also require blood culture for diagnosing, and it is usually positive in 50 to 80% of the patients. And the abscesses that are caused by gut deriving organisms require active exclusion of significant colonic pathology. So to exclude this significant colonic pathology, you need to you subject the patient to undergo sigmoidoscopy to see whether there is any colonic obstructions that are being present. So what will be the management? The management includes antibiotic therapy. That is initially you start them on broad spectrum antibiotics, followed by culture specific antibiotics, and then drainage of the abscesses. So sometimes if the antibiotic response is not appropriate in those patient, or the patient is deteriorating, in those conditions it is better to aspirate or drain the abscess with a pigtail catheter, and sometimes open surgical drainage is usually advised. So coming to hydatid cysts. So you all know that in your microbiology you have already seen these slides of hydatid cysts. These hydatid cysts, these are usually caused by Echinococcus granulosus, and these cysts have 3 layers. This is outer layer which is derived from the host, intermediate laminar layer, and inner germinal layer. What is this germinal layer contains of?
Brood capsules, daughter cysts.
That brood capsules are usually present. So brood capsules are the
Daughter cysts.
uh, Come on, come again, come again. You're right. Brood capsules or
Daughter cysts.
daughter cysts. Yes. So these hydatid cysts can be single or multiple. When they are chronic, they may get calcified. So these cysts are usually asymptomatic, and if symptomatic, the patients may present with abdominal pain or mass. And in patients of hydatid cyst, on routine blood investigations, you see eosinophilia is present, and X-ray shows calcified rim of abscess. Whereas CT is reliable for diagnosing of this cyst, and the reliable blood investigation of choice is Echinococcus enzyme linked, that is Echinococcus ELISA, and it has a sensitivity of 90% for hepatic hydatid cysts. So there will be in any cyst there is a chance, every chance of rupture or secondary infection, and in some cases there will be communication with the intrahepatic biliary tree. So usually these are treated medically with albendazole or mebendazole. If there is a communication with the intrahepatic biliary tree, in such conditions, if there is no communication, if there is no communication of this intrahepatic biliary tree, then these cysts can be, there will be percutaneous aspiration of cyst, and followed by 100% ethanol into the cysts are usually done, and after that there is reaspiration of the cystic contents is done. With this procedure, this entire procedure is known as PAIR, percutaneous aspiration with injection of ethanol and reaspiration. So if you remember this term PAIR, it is done in cases when there is no intrabiliary tree communication. So if the cyst is intact and identified, it is always advisable to remove the intact cyst. Next, coming to amoebic liver abscess. So most of the then so amoebic liver abscess, you all know that it is caused by Entamoeba histolytica infection. So, and it is most found in endemic areas. Abscesses are usually large, single, and located in the right lobe. These patients are usually present with fever, right abdominal pain, and swelling are the most common symptoms. These patients have on examination, these patients have tender hepatomegaly, and they present with fever. The fever in these conditions will be associated with chills and dryness. So analysis on ultra. So how do you diagnose this amoebic liver abscess? What is the color of the pus in amoebic liver abscess?
Anchovies pus.
Yes, you're right. Pus is present. And what is the shape of this Entamoeba histolytica? What is the shape?
Slipper shape.
Pardon? Come again? These are
Slipper
flask
shape,
shape.
sir.
Flask shape. So these amoebic liver abscesses are most often found in endemic areas. So on a routine examination, on ultrasound abdomen, on examination, you will see on ultrasound abdomen, you will find this cyst, and by when you try to aspirate, you will see Anchovies pus, which is a typical characteristic of amoebic liver abscess. So in cases analysis with Entamoeba antibodies immunoassay, it carries 99% sensitivity and more than 90% specificity. Then what is the treatment of choice? Usually metronidazole. That is nitroimidazoles are usually given. Out of this, metronidazole is usually given at a dose of 800 milligrams thrice daily for 5 to 10 days. And apart from metronidazole, tinidazole or onidazole can be given at a dose of 2 grams per day for 3 days. As an alternative to metronidazole, nitazoxanide is also given. It is given at 500 milligrams BD for 3 days. So, if the patient doesn't respond to metronidazole and metronidazole alone, in these patients, metronidazole along with nitazoxanide can also be given. So, other alternatives are diazonide fumarate or a paranomycin is given 500 milligrams thrice daily for 10 days after treatment. These dianoxide fumarate and paranomycin are usually given 3 times daily for 10 days after treatment. So these dianoxide and paranomycin are usually given to eliminate the luminal cysts. Okay. If and in case of liver abscess is usually large, it is more than 200 ml or so, and if it is a liquefied state, then it is better to aspirate, because there will be every chance of rupture of this abscess. So when there is a rupture of this abscess to the pleural cavity or pericardial sac or peritoneal cavity, it causes infection. So there is you should immediately aspirate, or you do surgical drainage of these cavities. So how do you prevent? How do you prevent this liver abscess? So prevention is by not eating the fresh fruit, eating fresh fruits and vegetables after thorough washing, and not eating the uncooked vegetables, and drinking clean water. So these are all the precautions you should be taken. So here we complete the benign tumors of the liver. So we will be dealing with malignancies of the liver, that is hepatocellular carcinoma and all other malignancies in our next class. So with that, we will be completing the GIT. Is there any topics left apart from malignant liver tumors? Pawan?
No, sir. No, sir.
Everything in GIT is completed except malignant liver tumors. Am I right?
Yes, sir.
Yes. So in next class we will be completing the malignant liver tumors and completing the GIT. Okay.
Okay, sir.
Okay.